Thanks for joining us today for a Mayo Clinic chat. I'm Vivian Williams, talking today about the nation's opioid epidemic with Mayo Clinic anesthesiologist and pain management expert Dr. Mike Hooten. Now, I have some statistics to tell you about. The Centers for Disease Control and Prevention says each day 78 people in the U.S. die of opioid overdoses and more than 1,000 are treated in the emergency departments. Now, Dr. Hooten, we want to know a little bit about what's happening and what needs to happen to take care of this opioid epidemic. Thanks so much for joining us today, Dr. Hooten.
Thank you. It's nice to be here.
Thank you. So I want to start out with a question that I have here on the paper, but I want everyone who's watching to know that we're going to try to take as many of your online questions as we can today. So get them to us and we can talk to Dr. Hooten about them. So we hear this term, the opioid epidemic or the opioid crisis. What exactly does that mean?
The opioid crisis is a term that refers to the large number of accidental overdoses that are directly related to the use of prescription opioids for non-medical purposes.
And do we know how many people are using them?
It's in the tens of millions of people in the United States. That number fluctuates with time.
What is an opioid? I think there's confusion about what exactly we're talking about.
There's two important terms. One term is an opiate. The term opiate refers to those naturally occurring substances, for instance, heroin, opium, that are derived from the poppy seed itself, from the plant itself. Opioid refers to those synthetically manufactured or designed drugs like oxycodone, hydrocodone, those types of drugs. Another example, morphine, that is an opiate. However, we often use opioid to refer to that. So in the modern era, opiate typically refers to those drugs that you may see on the street. Opioids are those prescription drugs that are typically abused.
So how does one become addicted to these drugs?
It is very easy, and people come to develop these problems in a multitude of avenues. Typically what you might see is an individual with an acute pain problem, either post-operative use or possibly a chronic pain problem, and they're exposed to these drugs initially. Over time, people will start misusing them for their obvious the flip side of the pain coin, which would be the psychogenic effects, the calming effects. Some people use them to facilitate sleep, and then unknowingly they will become physically dependent, which then can lead to overt abuse of the drugs.
Okay, I think so. You know, some people who take them feel like they really need these drugs because they're in pain, they want it to go away, everyone wants their pain to go away. So when is it appropriate to use these medications?
I think one of the most regularly used or maybe considered appropriate indications would be for acute postoperative pain.
Okay.
So you have an operation, a knee replacement, or abdominal surgery. These drugs can be prescribed for 3 to 5 days afterwards, at which point people taper off and they don't use them. However, we published data that shows about 1 in 4 individuals who are prescribed under those circumstances may go on to use longer-term opioids for a variety of reasons.
And playing devil's advocate a bit, why not? I mean, what is the harm if you're in pain of taking these medications?
Yeah, because over time, again, you can develop dependence, and you can develop abnormal behaviors related to their use, which would indicate the presence of addiction. But also over time, with continued and longer-term exposure, the drugs actually lose their pain-relieving effects.
So you have to take more of them, maybe?
So therefore, the dose will spiral upwards.
Okay, and I'm going to turn to some questions in just a minute, but I have a few more I want to go through with Dr. Hooten before we get to your questions, so just hang on for a minute. What's happening to your body? If you're taking these opioids, yes, you may become addicted, but how does that happen to your body? Why can't you just put it down one day and say, I'm not going to take any more?
Mm-hmm. The neurobiology of addiction is very complex, but core to addiction, whether it's from cocaine, opioids, alcohol, even marijuana, it's the dopaminergic system. So these drugs potentiate the activity of dopamine in the deeper structures of the brain, which have to do with a lot of very fundamental elements of existence, like drive, appetite for certain things, including drugs. So it really, you start affecting the appetite for these substances.
That's very interesting. And when one becomes addicted, you think about alcohol addiction, and then when you're stopping drinking alcohol, you can get very sick. Compare alcohol withdrawal with opioid withdrawal.
So alcohol withdrawal can be a lethal state. Heavy alcohol users, if they abruptly stop or reduce the amount, they can have withdrawal seizures. They can develop abnormalities in their heart rate, blood pressure, heart rhythm, and they can even die from it. Opioids is different. Opioids is considered a non-lethal withdrawal state, so that when you abruptly stop or significantly reduce your dose, within 24, possibly 36 hours, you will start experiencing withdrawal symptoms, which typically involve a feeling of anxiety, restlessness, sleep disruption, cold sweats, and just feeling very ill at ease. You can also have, in more severe states, elevations in heart rate and blood pressure. But again, you do not have seizures, and it's, again, considered a non-lethal state.
Well, that's good news, because I think people worry about
Yes.
that.
Correct.
How bad is it going to be? It's going to be bad, but it's not going to kill you.
And typically in the acute withdrawal syndrome, pain will elevate. So not only will you have aches and pains in your joints and muscles, but for whatever, but the initial pain problem will typically intensify. So for example, if you have low back pain, your low back pain will intensify during that withdrawal state.
Okay, and we talked about how you become addicted and when it's appropriate to take these medications. I do want to get into what are some alternative things you can do if you don't want to take opioids. But first, I want to go to a couple questions. Here's someone's question. I don't have their name, but there's a question that just came in that said, are there any long-term effects of taking oxycodone for chronic pain?
Opioids are very easy on the body. So, for example, they do not cause, end organ damage to the kidneys, the heart, the liver, the lungs. So the body metabolizes them very well. Unlike other drugs, for instance, alcohol, which can have be associated with end organ damage, opioids are not associated with those types of problems. However, some of the adverse side effects will not get better with time. So, for instance, constipation is the most common adverse effect that typically is present throughout the duration of use of the drug.
So the person who sent that in might be saying, well, if there are really no long-term effects, why can't I take them? Yes,
because the risks of addiction and it's hard to explain until you see it firsthand, the human component of that and how it just robs people of their lives, robs of their families. It's just devastating when it does develop.
Let's go into that a little bit more, just so people can understand what the risks really are. If you become addicted, what are some of the behavioral issues that might happen? How does it change you? How does it negatively impact your family? That sort of thing.
Mm-hmm. So some of the behaviors that you will see, I think, primarily center on a focus on the drug. So individuals will spend the majority of their day really focused on the opioids and then the indications for why they're taking them. So they'll become very pain and very medication focused. And then you'll start seeing a deterioration in their overall level of functioning, both socially, but physically they'll become less active. They may become socially withdrawn, again, from work, but also from family members. And the totality of really the existence, it becomes more and more focused on getting the drug, fears about not getting the drug, and using the drug.
Yeah, well, I know firsthand people who have had family members that really struggle with it, and it just tears people apart because they're focused on that drug and not on their family. Let's check out another question here. So what is the feeling that users get from heroin? Why do people start drugs if they don't have a condition? So that's a two-part question. Why is heroin so attractive?
Well, it's interesting. So heroin use has really shifted in the past 10 years. It used to be, before the prescription opioid epidemic, people really only had access to heroin, obviously on the street. With the development of the opioid epidemic, heroin use is making a comeback, because if a person can't get their prescription opioid, or they can't get it either through legal or on the street, then they will use heroin. So there's been a big spike in heroin use over the last 3 to 5 years.
And that's dangerous because?
It's dangerous because these individuals who are used to taking a more prescribed and quantified amount in a pill, all of a sudden are being exposed to a substance where you don't really know the strength of the drug. Again, you don't know the concentration, and there have been many, many accidental overdoses related to individuals using heroin who are not necessarily experienced heroin users. It's tragic.
It is tragic, and people watching, and you may have even seen that picture that was in the paper recently of the couple who had overdosed, I think it was heroin, I'm not sure, and there was a baby in the back.
Yes,
And
I
because
did
they
see
didn't
that.
realize the heroin was laced with something else, so it's kind of Russian roulette. You really don't know what you're going to get.
And there were those two parents sitting in the car with a little child in the back. Yeah.
Isn't that terrible?
Yeah, breaks your heart.
It's so sad. So we lost the second part of that question. I forgot what it was. Do you remember what it was? Oh, well.
And the feeling that people get with heroin.
Yes.
Yeah,
Thank
so-
you. Tell us about
Yep,
that.
So people will administer heroin several different ways. IV is the classic way, although many prescription opioid abusers will not use the drug IV. They will not shoot it. However, they will, you can pop it, which refers to kind of putting the substance underneath the skin, and then it'll just be absorbed, or they will smoke it. And typically, it's a very potent drug, and they will get a very quick rush as it hits the brain. So it's a very intense high.
Intense high, and sometimes I've had conversations where people think prescription drug abuse and overdoses are completely different than heroin, and that's not true because it's a door that goes to the next one.
Correct. And also what you'll see is that if an individual can't get the prescription opioid, they will use heroin, but then when the prescription opioid becomes available, they will transition back to that. So this is a group of people with drug problems that actually prefer the prescription opioid over the heroin.
Mm-hmm. Oh, it is a sad thing, and I hate to think about the stigma that goes along with drug use now, because people say, oh, I'm in pain and I'm using oxycodone or hydrocodone. Are people going to think ill of me? Some people really need that medication. How do you mitigate that situation?
Yeah, and this is a concern that many people have. In other words, those individuals that benefit from the drug, right? How do they take these medications without the overt bias? And it's difficult, and I don't know if there's a good answer for that. However, those individuals that do use them, typically use them responsibly, and with adequate follow-up and surveillance by the prescribing physician.
And I was just thinking about, where in the world do you go to get heroin? Apparently, it's pretty easy to do that. And where do you go to get your prescription drugs? I mean, how can you keep getting them if you're addicted to them?
It's very interesting. The CDC has long had this nice little pie chart, and it's been true now for at least 10 years, that approximately 70 to 75% of people that misuse opioids get the drug from a single supplier, which is a single provider, either a physician or an advanced practice provider.
We're not pointing fingers at people, because people are being prescribed medication because
Right.
they really think they need it. There's pain. And then they share it, perhaps with family members, which may not be a good idea,
Right.
but...
And so that they will share it. But also what happens is it will be stolen. So a family member will steal it, or they will take half, for example, and then sell the other half. So there's lots of problems with diversion once these medications actually leave the pharmacy. We really don't know what happens.
So, hypothetical situation, a parent or someone has a child who's suffering because they got their wisdom teeth out, or they fell, or something, and they're suffering and they want the suffering to stop. What's wrong with giving them one pill?
Because everything starts with one pill.
Oh.
And I think that is the biggest problem. Again, it's nobody's intention to have these medications, be used longer than anticipated. Also, individuals that may be predisposed to addictive problems, again, it just takes that one pill, that one drink, to possibly start a cascade of events that can be very troubling down the road.
Okay. And I'm going to talk. Oh, I was looking for another question here that's coming up. Good question. Is Tramadol an opioid? I think there's misconceptions about this.
Tramadol is an unusual, a hybrid drug. It does have activity at the mu opioid receptor, which is the primary receptor in our brains and in our bodies that are sensitive to these drugs. But it also has another effect, in that it inhibits the reuptake of norepinephrine in the spinal cord, in certain fibers that help turn off incoming pain signals. So on the one hand, yes, it's a weak opioid, but on the other hand, it works through a different non-opioid based approach to help with pain.
Is it addictive? Should you worry about that?
Yes, people abuse Tramadol. The typical dose it always comes in 50 milligram tablets. 8 tablets per day is considered the maximum dose, but then we see people who abuse it that take up to 20 and even 30 tablets a day.
Okay, another question here. So are there new, oh, this is another very good question. You guys have great questions that you're sending us. Are there new medications on the horizon to replace opioids? That's a great one.
That is a very good question, because we always hear about drugs in phase 1 and phase 2 trials, and they get a lot of attention, so they've made it through the animal studies, but yet as they move into these later phase, like phase 3 trials, something seems to happen, an adverse effect or another problem that derails it. So at the current time, I'm not aware of anything that's an opioid-like drug without the associated problems with addiction. I'm not aware that that's going to be on the horizon, at least for the next year or 2 years.
Well, year or two. Maybe we can wait that long, and hopefully there'll be something. But I imagine that people could potentially flock to that. You just wonder about one addiction being replaced by another.
Right. Yeah. And it all depends on the pharmacology of these newer agents.
Exactly. So here's another good question. What role, if any, do you feel pharmacogenic testing may play in the pre-screening process for prescribing these drugs to patients?
It is not clear. That's a very complex arena, and the clinical correlation or the clinical significance of this testing has yet to be fully vetted. So it's not really clear how helpful it's going to be.
Okay, that was a very good question. One more question here. So someone just sent in, after 12 years on opioid prescription pain use, can someone be addicted? Yes. And what do you see for future pain relief? So I'm going to re-ask that question. I think people want to know that if you're not going to use an opioid, what other options are there?
Right. So basically we're talking about non-opioid based approaches to managing pain. Pharmacologically, there are FDA-approved non-opioid analgesics that are effective for certain conditions. Many of these drugs, folks with chronic pain are aware of them: gabapentin, Neurontin, Lyrica, pregabalin, duloxetine, tricyclic antidepressants. Again, good evidence showing efficacy for certain pain problems. There's another approach where we can start talking about behavioral aspects of managing pain, because many patients get to the point where the underlying physical problem, it's difficult to manipulate that, it's difficult to address and treat that. However, many of the psychosocial variables you can change and you can alter, which clearly can have a very advantageous effect on not only pain severity, but more importantly, quality of life and functionality.
So if someone watching has back pain, lots of people have back pain, maybe they were in a car accident, they have a real injury,
right?
How is going to a pain clinic such as the Mayo Clinic pain clinic, how is that going to help with pain that's really there?
So talking about the pain rehabilitation program?
Yes.
So the pain rehabilitation program is a 3-week outpatient program that just focuses on functional restoration. So they teach individuals ways to manage pain using alternative approaches, oftentimes meditation, relaxation, imagery, but at the same time they couple that with individualized exercise programs focusing on enhancing not only core strength, leg strength, but also aerobic capacity, because it's very clear that, to put it very simply, a weak muscle is a painful muscle, and if those weak muscles are in your back, that can contribute to your ongoing problems with back pain.
Very interesting. So there are lots of ways you can work around pain without taking opioids.
Yes, and then again, that's more of a holistic, a more complete approach to how we think about the effects of pain over the life cycle.
Okay, and it's interesting, back in the day, Civil War or whatever, you'd bite on a whiskey-soaked rag to deal with getting your leg chopped off. And now, God forbid, that's a horrible thing, but that's what they did.
Right.
Or they had ether, and it seemed like pain management has changed to be so good that we're used to being pain-free, and we expect to be pain-free, whereas maybe before we weren't. Right. Is there any truth to that?
I think that is a very important core concept, because at some point it may not be realistic for an individual to say, I want to be pain-free. And when that occurs, then the medical model needs to shift from more the acute biomedical approach, where we want to make this problem go away, shift it towards how can we enhance quality of life, maintain functionality, so that you can continue to enjoy your life even though you do have to struggle with this pain problem. very analogous to diabetes. We can't cure diabetes, but there sure are ways that you can manage it and live a full, successful life and avoid many of the complications that may arise from diabetes.
Okay. Another questions? We don't have any coming yet, so please, if you have questions, send them to us. I do want to comment or ask you about people who are debilitated by chronic pain. Chronic pain is a huge issue in this country and elsewhere, and people are depressed, they're suffering, they lose quality of life. Where do they even start? If they can't have an opioid to get them through the day, where do they start?
Well, I think a good place to start is to have a very open and honest conversation with your physician or other provider. Talk to them about not just the pain level, let's get beyond, oh, my pain is a 7 or an 8, and start talking about the problems associated with pain. For instance, depression, because we clearly know that depression by itself is a risk factor for pain, and chronic pain is a risk factor for depression. So what we have are these significant comorbid psychiatric problems that exist and are actually linked into similar brain regions that's also processing pain signals. So it's very important to kind of open up and open the mind and start thinking about trying to get linked in with individuals that can be helpful. So, for example, pain psychologists are very helpful at helping people understand these problems and get some real solutions to them.
Okay. Yeah, because these people that suffer are not making it up. They're suffering.
They are suffering. Correct.
Absolutely, absolutely. So, back to the sort of question about where people go to, if you're in that mode of suffering from chronic pain, do you reach out to your healthcare provider? Where do you start?
I think that is a good start. Is sit down with your provider, but then at the same time, I think the individual needs to be aware that there are other approaches that are helpful that are going to be beyond kind of the typical biomedical model. And that means what type of behavioral treatments are out there, and can that individual be referred to them? Now, if you're just kind of trying to look for that individual, you can search your list of healthcare providers in your insurance plan to try to find an individual, for instance, a pain psychologist that has specialized training in this, or you can also look for a pain medicine specialist as well, who also have expertise and understanding of these important other treatment approaches.
And we just got a question from someone watching, which is perfect for right now. What about alternative medicines like acupuncture, things like that?
There's a whole list of alternative approaches. Acupuncture, for one. Acupuncture can be very helpful for certain conditions. It's been around for 5,000 years, so yes, it is very helpful. And we try to incorporate as many meaningful alternative treatments as possible, but the individual has to be careful, because there are a lot of things that you can investigate and look at on the internet, and people will try to sell you something, but maybe the efficacy is simply not there.
Okay. But, whatever, if it works and it's not hurting you, maybe try it, right?
Yes, that would be correct. I would agree with that.
Okay, and I want to ask a question about backtracking to when you're taking too many opioids and the risk of overdose death. How does that happen?
Yes, that's an excellent question, because again, the majority of deaths that we're seeing in the U.S., they are unintentional. So here's a typical scenario. An individual will be taking typically possibly higher opioids, so maybe at a dose of 90 to 120 a day of morphine equivalents, right? But typically what you will see with most accidental deaths, there will be a benzodiazepine on board. And that drug is the Xanax, Ativan, Valium-like drugs. And the reason that's so critical is because there's synergism between those two drugs with regards to both sedation and respiratory depression. So most of these accidental deaths are polydrug overdoses. So opioid, a benzo, you will also typically see possibly alcohol, possibly marijuana on top of that, and then you can see the muscle relaxants, the Flexerils and things like that. Heath Ledger, if people remember him, is a perfect example of an accidental death. He flew in from London. I've looked at this in quite a bit of detail. Came into New York, had to do some acting stuff, but he needed to get a good night's sleep. And so he took an opioid, he took a sleep agent like Ambien, he took a benzodiazepine, and he drank some alcohol, and he did not wake up.
Oh, and
Classic example.
thinking that he was doing the right thing to get a good night's
He was
sleep.
trying to get, it was clearly an unintentional stacking of substances. And this can occur even with individuals that have opioid tolerance. You can overwhelm your tolerance and again be pushed over the edge.
And it's not
and
just,
wake up.
yeah, it's not just, all of those drugs. I mean, he was on 4 or 5 different
Yes.
substances, so even 1 or 2 mixed could be a problem. So if I take one opioid, can I have a glass of wine, sort of thing?
Right, or opioid, and then can I take my Valium and maybe an extra dose of Valium because I really can't sleep or I'm feeling very anxious tonight. And that's kind of a typical pattern that you will see.
Oh, yeah, 1 is good, well,
tragic.
2 must be better, right? So you
Right.
really need to talk to your healthcare providers to make sure you're taking these medications properly.
Right.
Okay, another question came in. If you want to get off opioids, what's the best way to do it? And where can they go for help?
Yes, this is becoming an increasingly important clinical problem in our current environment. Number one, opioid tapers are most successful when they're medically directed. Okay, so how can we gradually reduce these drugs to avoid the acute withdrawal, which we know is going to amplify pain? So slow tapering, but at the same time the medication is being tapered, there needs to be other approaches to managing pain, and that's the beauty of Mayo's pain rehabilitation programs. So in the context of the 3-week program, they will taper the drugs and provide you other mechanisms and ways to effectively treat your pain.
Yeah, because it's important to get it under control.
Absolutely.
Because you'll never get off if you're, still struggling with the pain too much.
And if you don't have the coping strategies and mechanisms in place, then your odds of being successful staying away from the opioids long term are very diminished.
And what do you, when you talk about tapering, what does that mean?
Tapering is just a gradual reduction of the opioid. So for example, if you're taking oxycodone 5 milligram tablets and you're taking maybe 10 a day, that would be 50. Then one strategy would be to reduce by 5 milligrams every 2 or 3 days. There are times when it may be more appropriate to reduce 5 milligram tablet every 5 to 7 days. Again, it depends on the situation and the available resources to help guide and ensure a safe and successful taper.
Mm-hmm. In this series that we did together that we're putting on the Mayo Clinic News Network, one of the first story we put out was one about the kind of the changing face of addiction. And so we used to have this image of, junkies shooting up in the alley or whatever they were doing, and that's really not what's happening now. I mean, and who's getting addicted to these drugs?
Yeah, and that's the tragedy. That it's a tragedy for those that are unfortunately homeless and truly living on the streets and abusing in drugs, and they have drug addiction problems because there's horrible comorbid psychiatric illness as well. So that's an important group. But now, as we've seen with this so-called opioid epidemic, what we're seeing now are individuals that are our work colleagues, they're our neighbors, or our family members. The majority of them are in their 20s to 30s. The majority are overwhelmingly Caucasian. And there used to be a majority of men, but now we're seeing that kind of equal out. So there's equal number of women and young men having and developing these problems.
Okay. Well, Dr. Hooten, I think I'm getting the sign to wrap up. Not quite. We may have one more question coming up. We don't have another question, but I have another question for you.
Mm-hmm.
And what would you, in kind of closing, what would you like people to know? What's the bottom line about if you're taking an opioid? What should you be concerned about? How do you know if you're addicted? And if you think maybe there's an issue, what should you do?
Yeah. If you suspect that you may have a problem, I think the initial first step is to talk honestly with family members, your spouse, your children, because they will have a better estimate possibly of what might be going on than you do. And then number two, I would just like to send the message that you can taper opioids and you can live an opioid-free life, but still maintain high levels of functioning, high quality of life despite pain using non-opioid based approaches.
So there is a support system if you reach out there to get it. There's a support system that can help you, like at the Mayo Clinic Pain Rehabilitation Program.
Yes,
And
at all 3 sites now.
So Arizona, Florida,
Yes,
and Rochester.
And Rochester. And one more parting
Yeah.
thought is that it always is distressing when individuals feel like there's no other place to turn. And I would just send out a word of encouragement that there's always hope, there's always alternative approaches, and never feel like you're at the end of the rope.
Dr. Hooten, thank you so much for your time, and thanks to all of you for tuning in for our conversation about the national opioid crisis. And if you need some more information, you can visit mayoclinic.org. There's lots of information there that can help you no matter where you are on this journey. And if you want more resources, follow Mayo Clinic on Facebook. Thanks so much for joining us.